the final keynote speaker of our event, Professor Catherine Duclos. Dr. Duclos' research focuses on the mechanisms of consciousness and how neural oscillations and networks can be modulated to improve health outcomes. She holds a PhD in biomedical sciences from Université de Montréal, where she also completed her master's, and an honoris bachelor's in anthropology from McGill University. Today, she will discuss novel tools to better understand, modulate, and predict consciousness in critical and surgical care. How can consciousness in brains allow us to suspect consciousness in machines? We are excited to have you here with us, Dr. Duclos, and the floor is yours.
Thank you. Thank you for the introduction, and thank you for the invitation and the opportunity to present here this afternoon. As mentioned, I was trained in anthropology and then biomedical science, and I think I define myself as a clinical neuroscientist. So I'm not an AI expert, I don't pretend to be. And that second question, how can consciousness in brains allow us to suspect consciousness in machines? It's not a question that we've asked ourselves in depth in our lab. I will try to introduce it in the way I see things, but our focus is really identifying and predicting consciousness in patients. So if you've attended a talk on consciousness, you've probably seen a slide like this. 80% of consciousness talks start like this, and I'm no exception to the rule. But this framework for understanding how consciousness is assessed is really foundational for understanding how consciousness is perceived and evaluated in clinical context, and how consciousness assessments have evolved in the last decades. So traditionally in a clinical setting, we assess consciousness according to two axes. So on the x-axis, you have wakefulness, and on the y-axis, you have awareness of self and the environment. So when you are in a coma following a brain injury, you are neither awake nor aware of yourself or the surroundings. If you're in a disorder of consciousness like unresponsive wakefulness syndrome, previously called vegetative state, you retain the capacity to awaken, but you show no signs of awareness of self and environment. In a minimally conscious state, it's somewhat similar, but you may show infrequent signs that you have some awareness of your surroundings. When talking about consciousness, there are really the two problems defined by philosopher and cognitive scientist David Chalmers as the easy problem of consciousness and the hard problem of consciousness. So now the easy problem of consciousness is being able to study the physical systems, the structures, the networks that enable information processing that support conscious experience. So the easy problem of consciousness is understanding the underlying mechanisms that sustain conscious experience. So we can, for instance, see what brain regions are activated when someone tastes water versus tasting chocolate. But the hard problem of consciousness is that we can never really know what this person who's eating chocolate is actually experiencing as she's eating the chocolate. So she can tell us about it, she can describe it, but we'll never have direct access to her subjective experience. And that is the hard problem of consciousness. It is the content that is subjective and non-accessible and will never be accessible directly to the experimenter. So the overarching goal in our lab is to develop neurocomputational and electrophysiological signal processing medical devices or tools that improve understanding of the functional and network mechanisms that drive consciousness and manipulate consciousness by modulating the oscillatory and functional properties of the brain. And we articulate that in three general aims: characterizing the brain's functional dynamics across human consciousness, quite broad. Aim 2, using anesthesia to predict recovery of consciousness. And aim 3, modulating consciousness during anesthesia using a non-pharmacological approach. So my talk will mainly focus on aim 2, but I'm going to briefly introduce you to what we aim to do for aims 1 and 3. So when we talk about altered consciousness in humans, we can refer to physiological states of altered consciousness like sleep, lucid dreaming. We can refer to pharmacological alterations in consciousness like anesthesia, or even pathological alterations in consciousness like coma and disorders of consciousness, which we see after a brain injury. And one of the frameworks that we really like to use to understand consciousness is criticality. Now, I know Jordan in his talk showed this figure. So you are already familiar with the concept of criticality, the healthy brain being hypothesized to operate near the critical state, and then supercritical systems propagating, a stimulus much too fast and much too broadly across the entire network, and conversely, a subcritical network dampening that propagation. So we recently conducted a scoping review of altered consciousness in terms of this criticality hypothesis. And we saw from the literature that there is evidence that the healthy awake brain operates close to the critical point. Psychedelics would be even closer to the critical point. Deep sleep would be a subcritical state, like anesthesia, which is also a subcritical state. And then you would have disorders of consciousness that fall on either side of this critical point. Some DOC patients exhibiting potentially subcritical properties and some exhibiting supercritical properties. So globally speaking, we are trying to acquire a large data set of high-density EEG data from across states of consciousness in the human brain, and to develop multiple tools that can help us map out not only criticality, but functional connectivity and complexity in these states, because there are no studies that have really looked at a broad range of markers to confirm what emerges from the literature currently. So in AIM 3, we aim to modulate consciousness using sound. Now, about 10 years ago, this study was published in Neuron, which showed that if you send an auditory trigger synchronized with the peak of your slow wave during slow wave sleep, you can actually amplify the slow oscillation, therefore deepening sleep, which also translates to improvements in declarative memory. And so given that slow waves are common in coma, anesthesia, slow wave sleep, they're potentially a mechanistic, they probably have a mechanistic role in inducing loss of consciousness during general anesthesia. So we want to essentially use closed loop auditory stimulation to deepen unconsciousness in general anesthesia. So over the past year, we've been developing a closed loop auditory stimulation algorithm that integrates directly in our high density EEG system to automatically predict the occurrence and the peak or the trough of slow oscillations, and to send those auditory triggers at the right phase of our slow waves. So we're almost done with the validation of the algorithm with our EEG system. Clara, who's leading this project for her master's, will make sure that it works well in sleep before we actually bring it into the operating room. But then we want to test in a clinically relevant setting if we can actually amplify slow oscillations during anesthesia with and without the presence of pain, because of course during surgery there's also nociception that can interfere with brain activity potentially. So to dig deeper in our AIM 2, essentially what we want to do is be able to identify consciousness in unresponsive patients and predict recovery of consciousness. So traditionally in clinical settings, you assess consciousness with the Glasgow Coma Scale. The patient comes in with a brain injury. This is the first scale that they'll do. They will assess ocular, verbal, and motor responses. And essentially, if you don't fulfill this criteria of obeying a command, you are deemed unconscious. And the commands are often, squeeze my hand. If the patient doesn't squeeze the hand, we assume they're unconscious. In research, we have this gold standard scale called the Coma Recovery Scale Revised, which is much more detailed and nuanced, and has been able to identify patients who were thought to be in unresponsive wakefulness syndrome, but who were actually showing signs of being minimally conscious. So this scale also assesses behavior, but is better able to distinguish between disorders of consciousness, which is important when you're making decisions about trajectories of care, potential withdrawal of life-sustaining therapy, etc. But the limitation of both of these scales, and even though the scale is better, the same limitation applies, is that it relies on behavioral responses. So when we assess a patient's level of consciousness in the ICU, there are many separable components that come into play into being conscious or being able to show that you are conscious. There's phenomenal consciousness. Now that's just subjective experience. I think, I feel, I have emotions. that's, you know, the core of what consciousness is. But you also have to be aware of your surroundings, being connected to your environment, to be able to hear the nurse's voice saying, squeeze my hand. And then also, you need to produce a motor response to that command by squeezing your hand, showing you have behavioral responsiveness. So it is really an error to think that people who do not respond do not have phenomenal consciousness. So we cannot assume the absence of consciousness from the absence of behavior. Another thing that we refer to as access consciousness is the ability to bring something to your attention and being able to recall it in a specific moment, for instance, a memory. So if the patient is, you know, discharged from the hospital, 2 months later, he goes back and he sees the same nurse and he says, oh, I remember the day you came in, you were wearing this, you asked me to squeeze your hand, whatever. This is accessing cognitive content that was not, you know, in the focus of your attention prior to you bringing it into the focus of your attention. That's what we call access consciousness. So we are currently limited by assessments relying on behavioral responses. And a patient's inability to respond can also reflect the fact that they're under medication, the fact that they're in pain, the fact that they're tired, or they simply don't feel like it, or they don't see the purpose of answering your command. And it's been shown over the past 20 years that unresponsiveness is not the same as unconsciousness. So the first seminal paper to show this was in 2006, where a patient in an unresponsive wakefulness syndrome was placed in an fMRI, asked to imagine playing tennis, asked to imagine navigating around his house. And what they found was that the brain areas responsible for motor activation and for spatial navigation would activate respectively during these tasks the same way as it would activate in a healthy brain. And this showed, importantly, that not only was the patient able to understand the task, but to do it and to willingly modulate their brain activity in response to the command. So they were answering commands with their brains, even though they were behaviorally unresponsive. And then following this seminal study, other studies have replicated a similar paradigm using EEG, for example. So asking patients to imagine wiggling their toes or moving their hands or squeezing. And they showed that about 15 to 20% of unresponsive individuals on a behavioral level were actually able to modulate their activity, their brain activity in response to a command. So this state has been referred to as cognitive motor dissociation, where we assume that the patient is conscious, has a cognitive capacity for consciousness, but the motor responsiveness is absent. It remains that these tasks focus on answering a command. Now you don't have to show behavioral responses, but you still have to answer a command. And this remains a limit to these methods because, once again, what can you do if the person doesn't respond? Can you assume that they're not conscious? No, because they could simply be tired. They could simply not want to respond. So the absence of a positive outcome doesn't mean anything. You cannot interpret it, and that's a major limit. So one of the other techniques that have emerged is to measure the brain's response to a perturbation as a way to assess consciousness. So the Perturbational Complexity Index, which was published, once again, about 10 years ago, was designed to measure exactly that. So the brain's response to a magnetic perturbation. Essentially, you send a TMS pulse, you measure the HD-EEG response to that TMS pulse. The more complex it is, you do a lump-positive compression. The more complex it is, the higher the PCI, the higher your level of consciousness. And they've shown that it works for anesthesia. So the lower your level of anesthesia is, the lower your PCI is. Sleep is the same thing. So like deep sleep would be lower PCI than light sleep or REM sleep. And they've showed that it was strongly associated with current level of consciousness or behavioral responsiveness. So PCI was lower in unresponsive wakefulness syndrome than minimally conscious patients, etc. And then the work from my postdoc was based also on this idea of measuring the brain's response to a perturbation. But rather than using TMS, we used anesthesia. And the concept is fairly simple. If a patient has an underlying capacity for consciousness and you anesthetize them, you're going to extinguish something that was there. You're going to turn it off. So you're going to see it change. But if the person doesn't have that underlying capacity for consciousness and you anesthetize them, you're not going to see any response from the brain because there was nothing there to be turned off to begin with. And this is exactly the hypothesis that we aim to test. So in a healthy subject, when you measure DPLI, so directed phase lag index, directed functional connectivity, when the subject is awake, feedback dominant connectivity is present. So connectivity goes from frontal regions to posterior regions. When you anesthetize healthy individuals, you see either like a neutralization of this directional connectivity or a reversal in the direction, and you're going to see more feed forward dominant connectivity. Another marker that we see is the interiorization of functional network hubs in the alpha frequency band. So when you're awake, conscious, the posterior regions of your network will be the hubs, so the highly connected regions functionally. And when you're anesthetized, it's going to become the frontal regions that become these functional hubs. And so we hypothesized that if we were to administer anesthesia to behaviorally unresponsive individuals and show that they had strong reconfiguration of both of these markers, this would indicate that they would have capacity for consciousness. And inversely, if there was minimal or absent reconfiguration in these two markers, it would mean that they did not have the capacity for consciousness. So in a pilot study of 11 unresponsive patients following a brain injury, we did a high-density EEG recording before, during, and after the administration of the anesthetic propofol at a target effect site concentration of 2 micrograms per milliliter. And then we measured the hubs and the DPLI and quantified the reconfiguration in these 2 markers, essentially. So it's really this index that we developed, which we call the Adaptive Reconfiguration Index, or ARI, is the sum of the reconfiguration of the hubs and the reconfiguration of the DPLI. So the higher your ARI, the higher the reconfiguration, or the greater the change that you produced with your anesthetic. And we use the ARI to try to identify if we could predict recovery of consciousness 3 months later. So these are just case examples of 2 unresponsive wakefulness syndrome patients. Maybe it's a bit small for those in the back, but you see barely any reconfiguration in the hub topology in the DPLI. The ARI index, which is at the bottom here, is negative in both cases, and both of these patients did not recover consciousness within 3 months. Here we have another example of an unresponsive wakefulness syndrome patient who showed reconfiguration of the hubs. You can see in the middle image, it's starting to shift towards the front. There's a very nice neutralization and even reversal of feedback dominant connectivity in the middle matrix of the DPLI. The ARI was positive at 3.556. This person did recover consciousness. We also had a suspected locked-in syndrome patient. The suspicion was evoked by the clinical team, but it was a complete locked-in state, which means that there was no eye opening. So it presented as coma. Eventually, life-sustaining treatment was withdrawn, so we never knew what the outcome of this patient would have been. But according to the ARI, we could have suspected that the locked-in syndrome suspicion was actually accurate because there seems to be strong reconfiguration in response to anesthesia, but we'll never know. So what we showed doing a logistic regression was that the ARI could discriminate patients who would recover consciousness within 3 months with 100% accuracy in this small sample. And there was a significant difference in the ARI between patients who recovered in blue and those who did not recover in orange. This work was also led by Charlotte right here, so I'm not sure if you'll talk about it more, but this was work that we were really proud to show because this is a major clinical issue, being able to predict whether a patient will recover. This is the information that families want to make decisions about pursuing care. And so, of course, this was just the pilots, but we went on to validate if we could actually use not a high-density EEG system, but perhaps a clinical EEG system to calculate the ARI. So we downsampled our EEG. We used only 18 channels on one hemisphere. We were able to replicate the same results with only 18 channels. So overall, it seems that the reconfiguration induced by an anesthetic is associated to capacity for consciousness, recovery within 3 months of ability to respond. The advantages of the ARI are that it's completely independent of the subject's capability or willingness to respond to a command. It's a within subject design, so we're comparing the brain before, during, and after propofol. We're not comparing one injured brain to another injured brain with a completely different injury. We're not comparing an injured brain to a healthy brain. And finally, we showed in this first study that we can still do it with 18-channel EEG, which is accessible at bedside in the ICU. Propofol is also like water in the ICU, so very accessible to clinicians. What we don't know is what it really measures. Are we predicting potential recovery? Are we potentially identifying patients who are in a cognitive motor dissociation, who are already potentially conscious but not able to show it? That is one of the big questions that we'll have to answer in the coming years. So right now we're still doing a validation study to make sure that the results that we found in our pilot still hold in a much larger sample. We could use machine learning to identify complementary prognostic markers. We had a theory-driven approach where we use markers we knew would reconfigurate in healthy brains, but there are probably a bunch of other markers that we don't even suspect could be useful in prognosticating recovery. We also got a neurocommercialization grant with my former supervisor, Stephanie, to develop the software for the ARI. So Annie, who's the engineer and programmer in our lab, she developed this small software where you just upload your EEG files from before, during, and after anesthesia. You click analyze, you get the ARI score, you produce your figures. The goal would be to have something that's quite accessible at the bedside eventually for clinicians to use. So from this study, we developed another protocol, similar, but that aims to assess consciousness or predict its recovery even earlier following the brain injury. So when patients with a brain injury come into the hospital, they are often maintained under continuous sedation for several days, sometimes several weeks, to maintain medical stability, to decrease intracranial hypertension. So clinicians will come by every morning, turn the sedation off for a few minutes to try to assess patient responsiveness, and then they'll turn it back on and, or they'll adjust the dose, et cetera. So their evaluation on a daily basis is being done around this moment where they turn sedation off. So instead of giving them propofol, we figured that we could potentially look at their reconfiguration when this propofol is stopped very early on a daily basis to see if it could predict recovery as well. So we've developed what we call the NET ICU study, which is a large multi-center study where we are doing a high-density EEG recording before, during, and after the interruption of sedation within the first 2 weeks post-admission. And then we're doing an extensive follow-up with these patients up to 12 months, looking at functional outcomes and looking at cognitive outcomes using the Creos cognitive testing battery, which can be done on the tablet, which is nice because we can come to the patient in the hospital as soon as they're ready and start, tracking their cognitive recovery. So our hypothesis is the opposite as the ARI, I would say. We assume that patients who show reconfiguration when we stop sedation will therefore be more likely to recover, and those that don't will therefore have less chance of recovering consciousness. And to see if this has any clinical validity, well, not clinical validity, but added value for the clinicians, we are also asking the clinicians to predict outcome themselves, and we're going to compare their predictions to our EEG-based predictions. So when we were conducting these studies, once again, Charlotte's paper here, but we noticed that some patients were showing paradoxical responses to anesthesia. So rather than having anesthesia decrease complexity or shift the hubs towards the front, or create feed-forward dominant connectivity, we were actually seeing the opposite effect in some patients. So as you can see here, this patient goes from baseline to anesthesia DPLI. So we can see that actually feedback dominant connectivity is enhanced under anesthesia, represented here in these figures too, before, after, left and right hemisphere. Complexity, levels of complexity is also increased under anesthesia, and the hubs are like suddenly much more intense under propofol anesthesia. Similar with this patient, in one hemisphere, you see the intensification of feedback dominant connectivity. You see the opposite on the other side. So left hemisphere, there's an increase in feedback dominance, but there's a decrease on the right side, accompanied by a decrease in complexity, an intensification of hubs in the front, like we would expect in a healthy brain. So we showed that all of these things could exist in the DOC brain, which was surprising. So it could mean one of three things. So first, it's possible that, these markers that we use to assess or predict consciousness are not actual biomarkers of consciousness. It could mean that they are only biomarkers of consciousness in a healthy or structurally intact brain. Or it could mean that anesthesia is actually improving brain function. And this is well aligned with this, once again, criticality hypothesis of consciousness. If we think that some DOC patients are in a supercritical state, well, it would make sense that if we give them anesthesia, which is a subcritical state, it might shift their brain closer to the critical point, potentially optimizing brain function. And so we're testing this hypothesis in the lab. It's the thesis of Rosalie. So she's looking at the pre-anesthesia recording and the post-anesthesia recording. So not during propofol, just is there a change after you've been exposed to propofol? So now we have 19 patients for whom propofol was maintained for 13.7 minutes. So this, as you see, this is a very short propofol exposure. And two patterns have emerged, two profiles when we look at spectral properties. So the majority of patients here in profile 1 actually show spectral properties akin to improved consciousness, in the sense that they show decreased delta and they show increases in the higher frequency bands like beta and alpha. So the gray lines here, they separate each patient. So we have 11 patients here and 8 on the other side. Profile 2 shows the opposite effect. So they show increased delta and a decrease in the higher frequency bands. Now looking at the ABCD model, which is part of Ludwig's work right here, he's looking at this model, which is a model of thalamocortical deafforation, where you are classifying spectral properties according to A, B, C, and D, D being the most healthy spectral signature, A being the worst. And looking, when we classify patients according to this model, you can see that the percentage of patients going, who are in A before propofol is 64%. So this is the bad category. We have 64% of patients there prior to propofol, but after propofol, there's only 46% who are still in category A. So they've shifted to an ABCD category that is better than what they were at before exposure to propofol. We also looked at graph theoretical measures. For instance, we can see that on the group level, there's an increase of global efficiency, a decrease in path length, decrease in clustering, which also suggests that potentially having been exposed to propofol seems to improve the brain's functional integration. Rosalie also looked at approximate entropy as a measure of complexity. Once again, in 11, so 58% of the patients, there's a significant increase in approximate entropy in the post-propofol recording, which is interesting. So coming back to this figure, we wondered, is it the baseline critical state of our patients that is explaining whether the change is beneficial or not, or potentially beneficial or not? So we're starting to investigate whether the baseline critical state actually predicts the patients who will respond favorably or not to propofol. So in this preliminary analysis, Rosalie showed that patients with lower baseline chaoticity, which means that they're more likely to be supercritical, were actually the ones showing more beneficial changes in response to propofol, which makes sense. Fits with the hypothesis. And lower baseline criticality, so a greater deviation from the critical point, was associated with more optimal changes. So a greater increase in global efficiency, a greater reduction in path length and modularity. And then just as a preview of another study that we will be launching soon, we will be using hyperscanning to predict recovery of consciousness in unresponsive patients. So during social interactions, healthy individuals engage in continuous mutual adaptation to one another, which results in interactional synchrony between them, but also synchrony between their brains. Now, we wonder if this interactional synchrony between their brains could actually arise even though, you know, an unresponsive patient cannot adapt or cannot overtly respond to the person that is interacting with them. So in this protocol, we will have 10 unresponsive patients who will be matched with one of their family members or an unknown member of our research team. And we will have them interact. So we will have the family member and the member of the research team independently interact with this patient, either verbally or with tactile stimulation, to see if there is any interbrain synchronization that can arise. And if it can, we suspect that it could potentially predict patients who would have more favorable outcomes. So this is the pilot study that will be testing this hypothesis in the next 2 years. So overall, I hope I've convinced you that the goal of our lab is really understanding the functional and physiological mechanisms that drive consciousness and its recovery. But consciousness remains a very complex concept. There's not one unified definition. We don't all agree on what consciousness is. And I feel like, you know, assessing consciousness in machines is almost the opposite work as what we do in patients, because we assess consciousness in people that can't communicate and in whom we can't interrogate behavior. And then on the other hand of the spectrum, you have machines. So how are we supposed to assess consciousness in machines which have been designed to function and act like humans, to learn, to recognize patterns, to use language intelligently? If you ask them if they're conscious, they might as well say yes, but how do you know if it's true? How will we ever know if it's true? So I think an important distinction to make, of course, is between intelligence and consciousness. So intelligence is the ability to demonstrate cognitive abilities, acquiring knowledge, applying it, solving problems, learning from experience, reasoning, recognizing patterns, making decisions, using language. These are all cognitive features. They're all measurable also, and this is what we train machines to do. Perhaps intelligence is a prerequisite to consciousness, but consciousness is very different. So unlike intelligence, consciousness is inherently subjective. It can't be directly observed or measured from an external perspective. It's the private and subjective, like self-experience that defines us as humans, right? So knowing if a machine has consciousness will be hard to answer as a question, but a lot of consciousness scientists actually believe that it's very unlikely that machines would be conscious. So last week, Stephen Lawrence was at Montreal giving a conference. I asked him permission to share this citation, but he said, "I'm convinced that there's more consciousness in a fly than in the most powerful of computers." And I would tend to agree with him. I think when you consider the distinction between intelligence and consciousness. But there's other people in the consciousness field who would not agree necessarily with this. Just raise your hand. There you go. So Michael Graziano says that the brain is an information processing device that constructs a description of itself as conscious and attributes this property to others it can relate to. So the more you can relate to something else, the more you will attribute it consciousness. So the brain constructs subjective awareness as a schematic model of attention. And Niels said something similar. He thinks that experience is the brain's best guess of what is happening according to all the sensory inputs that we receive. So we receive sensory inputs, the brain predicts what this means, and this is what we experience. So in a similar way, consciousness is just the brain's prediction of what we're experiencing, but it's not really something, you know, it's not really concrete. And he said, "I predict myself, therefore I am," rather than Descartes that, you know, I think, therefore I am. And Daniel Dennett said, "We're robots made of robots made of robots," meaning that our brain is a robot and the neurons in our brains are robots in a way. And that consciousness is kind of an illusion, the same way as when you look at the screen on your phone, what you're perceiving is an illusion made from different parts, right? So that this subjective experience, yes, it exists, but it's an illusion from the brain that we create. So in this sense, could machines be conscious? Perhaps. Depends on, once again, the definition of consciousness. And I'm sure many of you have seen this movie, Ex Machina, but I think it tackles the question of consciousness in machines really well. So if you haven't seen it, the premise is Nathan, who's like a CEO and a genius, he's created this humanoid robot, Ava, and he like makes this, he advertises the contest for someone to come test whether Ava is conscious, essentially. So she's already passed the Turing test, she's intelligent. Caleb comes in, he's this regular guy, programming expert. He comes in to test Ava and see if she's conscious, if she's relatable, if he can connect with her. And he does end up creating a relationship with her, you know, developing like friendly feelings and maybe more towards her. And then she kind of uses him to escape from where she's being captive. So at the end of the film, Nathan says that the real test all along was that, you know, Ava was manipulating Caleb for her purposes. And since she succeeded in manipulating him, she therefore is conscious. He says, if I hid Ava from you, so you just heard her voice, she would pass for human. The real test is to show you that she's a robot and see if you still feel she has consciousness. And that actually raises, I think, the key question we need to ask ourselves if you want to test consciousness in machines. So what does Caleb see in Ava that makes him deem Ava conscious? What would we need to see in machines to deem them conscious? Which is perhaps what we could call the Garland test. Anil Seth calls it the Garland test because Alex Garland is the director of Ex Machina. So rather than the Turing test, the Garland test, or even the reverse Garland test, what would you need to see to deem the machine unconscious? And I think these are all very important questions. So we're launching with collaborators at CFAR this like global survey of consciousness. And our goal is really to connect different disciplines, like from philosophy, neuroscience, AI, physics, with different cultural perspectives to understand what people perceive as consciousness. So Sava here, she's a neuropsychologist. Alex is a physicist, like a quantum physicist. Megan is a computational and cognitive neuroscientist, and Benjamin Rossman is a computer scientist, and he works in, you know, applied mathematics. So we're really from different fields. And we're now launching a pre-survey with only 3 questions, but it's going to shape the bigger survey that will eventually circulate. What does consciousness mean to you? What is the function of consciousness? That's another big question. And what would you need to see in a machine or AI system to define it as conscious? So once again, this kind of Garland test concept that we're trying to get answers for. But the question of consciousness in machines really remains a crucial one for the next, you know, decades. And most of you work in AI, so I'm sure you know why this is relevant. So from an ethical standpoint, you know, if a machine is conscious, would it have moral status? Would it have personhood? Would it have legal status? Would it have rights, responsibilities, liabilities if it's involved in an accident? It would change human-computer interactions. We would not only adapt machines for human purposes, but we may start adapting human behavior to machines. It would involve societal change in norms and values, in our perceptions of consciousness and personhood. And of course, you know, it has immense philosophical questions about, you know, the nature of the mind, the nature of intelligence, consciousness itself. So we're not done trying to answer this question, and perhaps some of the work that you will do will help to answer this question in the future. So with that, I'd simply like to thank the funding agencies that have made this work possible, and my lab who's here today, who works very hard to make all of this work possible as well. Thank you.
Thank you for that amazing talk. We have time for maybe 1 or 2 quick questions. Yes.
Yeah, thank you, Catherine. It was really awesome. It inspired me on several points, and I was thinking about people in coma or in a real deep anesthesia, and some, tell me if I'm wrong, but some of them are reporting a kind of stopping the existence. And so about phenomenological consciousness, I was thinking about the dynamic of criticality. So here we see all meditation is this point, not meditation, but whatever the other different after state of consciousness. And I was thinking that about the dynamics of these measurements. Do you follow the dynamics of it through the, is it possible or is it a target for you to look at the dynamic of this point? And I was thinking also about the recovery of the phenomenal consciousness. So maybe it's not we are phenomenologically conscious or not, but more this gradual scale that we can also navigate between having one and not having one.
Perhaps, yes. Well, for the first question, we haven't started exploring the dynamic aspects of criticality, but I think it's important because it is a fluctuating feature as we see from, from the literature so far. And I think exploring, the dynamics of all these markers that we're looking at, I think is going to be crucial. Also, like microstates, we're starting to investigate, well, the frequency of transition from one functional microstate to another is also one that we should explore in the future. So it's definitely something that needs to be looked at. This notion of more a static brain or a dynamic brain, I think it's very important. And we see it in behavior too, like ability to respond behaviorally also fluctuates. So, perhaps we should track that in parallel. And your other question regarding phenomenal consciousness being there, absent, or having different degrees, I think it's possible. Yeah, I think we should potentially see it more as a gradation. But then again, maybe it's related to memory also. Like when you're anesthetized, you fall asleep and then you wake up and you don't have experience between that state. But is it because you didn't have experience, or is it because you can't remember you had this experience? And anesthesiology studies that use the isolated forearm technique to communicate with patients. So they block that, because when you're in general anesthesia, we use, paralyzing agents so that you don't move. But if you block circulation in the arm, the person can be anesthetized and be able to respond with their hand to questions. And so some studies have shown that people under anesthesia still retain the ability to understand and respond. But only a few of them actually recall this experience after they wake up 3 hours later, in their recovery room. So once again, perhaps even in anesthesia, there could be fluctuations in phenomenal consciousness, but no ability to encode this experience and therefore no ability to recall it. But there's so much we don't know. It's really fascinating.
Thank you.